Thanks to everyone. Great first couple of talks. And I'm following it up with a clinical practice review of how we manage cases in our emergency department. And this has been brought about not about root cause analysis, but about a few cases where I've had emails from respiratory team, thoracics, us, about the management of large pneumothoraces. And so I thought I'd just take us through a typical case that we probably manage very well. And then I've looked back at all the pneumothoraces were diagnosed this year, Footscray. I've done an audit, gone through exactly how they've been treated and looked at outcome. And then we'll discuss how we could probably move forward as a department with a large pneumothorax and how we could make it probably simpler for all of us. So this is a typical case, large primary spontaneous pneumothorax in a 20-year-old who turns up to emergency. And according to British Thoracic Society, then 2 centimetres at the Highland measurement, which is sort of where that cardiac lead is. Roughly, if that was bigger than 2 centimetres, you say that was a large pneumothorax. Pretty standard type stuff. I don't know why radiology tend to do this, but they sort of measure just the biggest spot, which can be on an oblique line or an apical measurement or that oblique one, or sometimes somewhere else. And you might get someone that says 6 centimetres or 5 centimetres. I don't think it matters greatly as long as you are following a standard eye measure here, apical or Highland, and I know which is large. This young gent is very well, walks in, had a pleuritic chest pain and went home because, yes, he had a significant pneumothorax. It was greater than probably 50%, and you should say that the resorption rate's around 2% a day. And then we come to this, well, how long is it going to take to get better for your first primary spontaneous pneumothorax? Let's just say it's 60%, 2% per day. If all goes well, in about a month, you will be well again. Okay. This is where we tend to fall into a problem of who looks at the next X-ray, who gets involved in the treatment next, and do we do it all ourselves? I'd say that we're probably best managing this all by ourselves in a well young patient and reviewing it at some point and then sending the patient home and saying thanks very much and I'll review you in a month. Come back, I'll have to do a chest X-ray for you in a month and we'll see if you've got better. Thanks very much. The end. This gent came back 8 days later because the emergency physician on that day knew they were on 8 days later, and they did another X-ray, which you can't see that well from where you are, but there is still a pneumothorax persisting here, and it's close to 2 centimetres. It's really hard to see on that. Very hard.
Actually, it looks improving.
But it looks like it's improving, but slowly. And is that okay? Yeah, because we were said originally it was going to take a month, so we're 8 days in. The funny thing is, the patient, being a patient, wasn't that patient, and was saying, well, hold on, why have I still got this pain, and it still hurts, and if I really try and run and get out there in the world, then it bothers me, like it's still really bothering me. So they then said, I'd much prefer to have it treated than leave it another 3 weeks of having this uncomfortable sort of feeling. Nothing worse than it just feels uncomfortable and it's annoying me when I'm out in the world. I'm a 20-year-old young bloke. So they then followed through our intervention pathway of how do we intervene in a pneumothorax, and was aspirated with a Cook's catheter. Again, there is a Cook's catheter in there. It's really hard to see. It's in the right fourth intercostal space. There's a little tip just pointing out lateral to where that cardiac lead is. Aspirated perfectly, watched in short stay for a period of 4 to 6 hours, and then has this tiny apical pneumothorax that stays there. It was late that night, so they went, okay, we'll keep you in short stay overnight, and then the next morning gets clinically reviewed and X-ray fine, Cook's catheter out and sent home. Now that's typical for what should happen. No problems, no complications, all is well. Everyone agrees on that management. Just following up for interest in Western health and how do our respiratory clinics go, I've looked at all the pneumothoraces for this year. So far, this person is yet to have follow-up in the clinic. this was one of the first cases in January. So we're currently about 4 or 5 months into waiting for follow-ups. Later, subsequently on the second admission, we go through a little bit more history than the first. This is just your primary first pneumothorax. And there was some recreational drug use, heavy marijuana smoking, some ice inhalation. If you look through the British Thoracic Society guidelines then, that's a secondary pneumothorax. So we've treated a secondary pneumothorax conservatively in that manner, and it's gone okay this time. So you agree, that's pretty standard practice for what we do. I did ask for a straw poll of who's done Cook's catheters this year, and Karen said she's done 1 this year. I know I've done 2. I know Ben's done 1. This is just a Footscray because I reviewed them all. So I know who's done what, and then I don't know how many everyone else has done this year, for instance. Maybe 1, maybe 2 would be the standard, possibly. 0? 0 or 1?
How many in your series this year?
I'll go through it. I've got a full Excel spreadsheet to show you all the stuff. And I didn't go through all the sunshines, but we're roughly matching, because I think we're a sort of respiratory unit and we seem to get more. So it's 50% each side. Looking at the information that I got out of EDIS and looking at our emergency management, that slide still sends me crazy. I cannot follow that as a consultant. So I don't know how any registrar or junior registrar follows that. I'm like, this yes, no comes to another arrow that goes down but left and right. And I think that's quite confusing for a number of emergency clinicians and people working in emergency medicine.
Then you can override it all if the patient should be well.
You can override it all because there's a little section at the bottom that says, and in some cases, you can, depending on your seniority or experience, just say, I'm happy to manage it conservatively.
It's the formatting that's the problem, really.
Yes, formatting is very wrong. So, in our minds, I'm sure we have a small side, which is less than 2 centimetres, and then a big side. And we have a small side, primary pneumothorax, no underlying lung, and we have the secondary lung problems pneumothorax. The secondary lung problems, I have a lung disease, pushes us into intervention much quicker and much earlier because it's not tolerated. That's how I really basically think of it, and I think it would make it a lot easier if we did that. There is this small group of the first primary pneumothorax, asymptomatic, with a greater than 2 centimetres who will tolerate it fine and can go home. That's the get out clause of, you're okay, you're 20 years old.
Except, like you're saying, those people are the ones who don't want to sit at home doing anything, they want to get about.
Yeah, because they're young men, generally, who want to get on with life.
Well, if they're on the isolation, they take us to have sex, it's really difficult.
And then, I think most, anyway, it's not for recording, don't think that has anything to do with us.
So, I just thought we'd look at all the cases we've had this year. So, this is them from the 1st of January through to last week. And I've been through every single one of them. 24 cases, 9 small, 15 large. The first measurement that you see is centimetres that I've measured off every chest x-ray. So I've gone back to the cases, pulled up the x-ray, and the external films I couldn't access other than someone has typed in large from the radiology department. Well, the CTs have been small CTs with a bulla or just a weird looking chest x-ray. From our perspective, there's quite a varied selection, I thought, of, they're not just all primary. There's a lot of secondary pneumothorax, and a lot of the secondary pneumothorax are there for significant asthma, COPD, a couple of traumatics that we've managed, but we managed conservatively. They tend to come in the small area at the top. So, fall from bike, another fall, and then we sort of go down into the COPD and asthma. The demographics of them, there's the young, 20 to 30s, and then there's the older group, 50s, 40s, 50s, 60s. And then we accrue a couple of people who've got really bad lung disease, severe COPD, who keep getting pneumothoraxes and blowing bully. So there's 2 patients I know at Footscray that keep doing it and keep coming back. and keep getting chest tubes. And there's a couple of elderly patients who have horrible falls, just slipped over, fall over on the side of the chest and get a large traumatic pneumothorax, get some ICC put in. So 24, I thought that's quite a lot in terms of 5 months. And then I looked at Sunshine, and Sunshine's accrued 12 cases. So 2/3 with a good screen and 1/3.
John, did you have a look at how many end up with a definitive procedure to...
Yeah. So here, ICC means some form of catheter has been put in.
I mean, as in a
That's-
therapeutic...
I can tell you that, I can tell you because I've been through all the cases. So this gent here had a secondary pneumothorax from COPD. He was sent home with a 3 centimetre large secondary spontaneous pneumothorax. It didn't resolve in 6 weeks, was followed up in respiratory clinic and went on and had VATS. I had a video-assisted thoracoscopy and then excision of a bulla, and then he recovered.
How did he get to the switch?
The consultant who was treating him conservatively thought I'd better call the respiratory consultant, the head of the unit, to tell them that I'm treating this gent conservatively, who's walked in with 4 weeks of chest pain, who then we find out he has a 3 centimetre secondary pneumothorax, and then he goes home and walks into clinic 6 weeks later, and then you do another x-ray and you go, it's still there. You go, right, we better treat it now. So then he gets into thoracics, and then they admit him, they do a CT chest, they find he's got a bullet, which is a bleb which is popped, and they try and put an RCC and it doesn't get better, and then this cascade of events happens. There's there's 2 others in this. There's one recurrent secondary pneumothorax in a 35-year-old who decompensates in ED and needs basically scalpel open, then a tube, and then goes to theatre, so tensioned in ED. And there's one other young man who, on his 4th presentation with a large pneumothorax.
The same one.
The same one. So back up the list, we go to the second list. This young guy down at the end here, he's been in now 5 times in 8 months. This recurrent pneumothorax just keeps coming back. So he's had VATS now, but he's still at risk again of maybe getting another one on the other side. So we might see the left side.
He's a smoker.
Yeah. So in the definition, just in British Thoracic Society, they say primary. If you smoke, you're okay.
You're still primary.
You're still primary, but you've got a 12% increased rate of getting a pneumothorax. Okay. And if you're secondary, if you've got a diagnosis of asthma, that's it. Any lung disease can give you an increased incidence of a pneumothorax. So if you go through the British Thoracic guidelines, they'll send out, you can look at anything, interstitial lung disease, COPD, asthma, bronchopneumonia, TB, HIV, PCP infection. The list is enormous. So if you ask anyone, they say, I've got asthma. You go, okay, you've got a second. And you're more likely to decompensate, so therefore you should probably need to.
So the marijuana ice is because of the inhalation of it?
Maybe because of the inhalation pressure. Maybe because of the inflammation. Well, they say that you get a white cell infiltrate, get a bleb, the small bleb then is at risk of popping.
More than cigarettes, maybe?
Don't know. It's out there in the world.
Yeah, it's just because they're not likely to decompensate any more than any.
Is it?
Like,
The risk of the pneumothorax itself, rather than decompensation.
Might be the unfiltered nature of it.
Yeah, it's just that the whole idea of being in the secondary category is that the complications of pneumothorax, the implications of pneumothorax are much higher. But you wouldn't think they'd be much higher just because you smoke ice.
Maybe the bomb guys just don't know they've got one, man.
Maybe they're unreliable.
Yeah, I think there's a sort of subset of what happens with that group of not the best reliable people. And
Yeah. I don't know, I'm just asking if smoking ice stuff.
to look at this, what happens with the large group, because that was a specific question. This is what we've done in the over 2 centimetres apical measurement. At the top, only 1 goes home. So 4 out of the 5 who've got a large spontaneous pneumothorax, who's young, 20, 26, 30, 20, goes home. And that's the one gent that came back and said, you know what, this is really annoying me, and then gets a Cook's catheter and then gets it aspirated.
Are they all, when you say ICC, they're all Cooks?
It's a Cook's. I haven't made a differentiation, I've just said you've had a facility intervention.
And if they had a Cooks and then we observed and taken out, is that all EOU or is it
Jack, the top one, Jack, went to EOU, had an aspirate through a Cook's and went home and has been fine. The second one, Helen, had a large primary spontaneous pneumothorax and was really symptomatic with it. So got a Cook's catheter put in, what goes to respiratory, because we say, oh, we've put in a Cook's catheter and aspirated 2.5 litres. She then gets admitted for 4 days, gets it taken out on day 4, and goes home, has been fine, has been followed up in respiratory clinic, has had a CT chest, she's got biapical blebs.
The moral of that story is don't send simple ones to the ward because they stay for 4 days.
But they think she's at increased risk maybe from familial genetics, because they've asked, there was a grandma who got a spontaneous pneumothorax, so that's one of the risk factors, familial genetics and primary spontaneous.
And she had the Cooks in for
4 days?
Yeah. Yeah, because it inflated. Day 2, consultant ward round, still a small one. Day 3, I will take it, we'll clamp it off now. Day 4, chest x-ray pulled out. Done. Thanks. Yeah. Adam, he was an unreliable recreational rec. It's the rec drug use. He was unreliable and needed a lot of consultant input to get him home and reassure him, who then comes back a few days later and just can't deal with it either. And the last gent is the guy who keeps coming back with this recurrent pneumothoraces that just hadn't treated.
And the one we decompensated, is it on the list or not?
No, I've pulled him out into the recurrent list here. So he's this guy, and I'll tell you why. Looking back at this guy who had a massive pneumothorax, like total collapse, 10 centimetres. It was honestly a tiny bit of one like that. He's got asthma. He's 35 years old. He got fluidic chest pain at 5 a.m. in the morning. Called an ambulance because the pain was that bad and they couldn't work out if it was anxiety or he was breathing quickly, or maybe it was because it was a whole, gets seen quickly, RASed, X-ray, large pneumothorax, no description on where we're at in terms of a recurrent secondary, because he actually says, I've had a pneumothorax before, but I think we've missed that clinically. And then he goes to EOU, and then an hour later, he's sort of tensioned. Yeah. And so I actually think he's a recurrent secondary and should have been intervention on arrival with a complete collapse of the lung. That's the, I think, risk we run with a RAS model and a rapid assessment on an ambulance bay trolley, and then a quick chest x-ray, and then you get divided into this stay in emergency, has to go to EOU, have to have an instantaneous decision. Whereas our protocol doesn't say large pneumothorax and you have to be watched for 4 hours in a monitored bed with a consultant who knows what's happening. So you can slip round to a short stay ward area with junior doctor. Yeah. With the secondary group, they all pretty much have an intervention in ED, except for Peter, who had a bulla up on an X-ray, and then has a CT that describes it as a bulla with no pneumothorax. And we did well because we convinced us and the respiratory team to just watch. Let's just watch and wait till we get the CT scan, and then we'll see if this is just a bulla and it's not a pneumothorax, because the guy walked in, so that's fine. So the outliers here are really big pneumothorax total collapse. I don't think we've looked at in any sense of our own sort of study. I think a reasonably large pneumothorax we can treat well, and we do. And we generally intervene if it's a secondary one. And there's a small number that we send to clinic for follow-up. And they have to be young men who are pretty well and reliable. That's it. The two cases that I was asked to look at, one is the deterioration. Is he going to deteriorate? I can't predict that, but yes, he was in hospital, yes, he was in a short stay unit, and the intervention he required, which was ICC, happened, and he's fine. So we sort of went okay with that. The other one was the large pneumothorax that was sent home, and then he had to go back to clinic, and then everyone gets confused on what do we do. If you're the emergency physician and you've seen a 80% pneumothorax and you've sent this young guy home, and he goes to a clinic where a respiratory doctor who might be a registrar has not seen as many pneumothoraces as you've seen, then they go, oh my goodness, that's an 80% pneumothorax, it has to have intervention now.
The way the outpatient booking systems was made, they're all triaged by someone, and so if it's a small pneumothorax, they might not be in for 12 months.
No, they won't.
So you're better off sending a big one.
You're better off calling the consultant today, the day that you see him, and saying, when is your clinic? Can he come along in 2 weeks' time to your clinic? And I can write your name down, who I've discussed it with, and I've got the patient's contact number. Otherwise, we start these email chains of, you did this, why did you do that? This is not according to our guidelines.
And just tell him to pitch up to that clinic on that day.
Yeah.
There's no guarantee, if you just do a referral to outpatients, there's no guarantee that anyone's going to see that referral, let alone...
Which is the worry of the whole referral with outpatients.
Yeah. So that's our problem with our follow-up model, which is why I think we should actually internally manage most of them, and we do the review for most of them, so that we know what we're doing, rather than
And if
involving
you're more
someone
worried
else.
than that, you refer on
Yeah.
correctly.
That's
Anne-Marie
it.
Southcote's pretty much said she would prefer to get a phone call about the patient who put them into clinic than receive some random fax.
So does she put them into clinic?
Until she sorts it
How
out.
does she do it?
She can put them in.
Because she can...
She looks at the letters and
She
the
controls the
Yeah,
clinic. so-
yeah, that's right. And the other, just as a slight aside, but the fax referral system, it sounds like it's got to go. The hospital's not acknowledging that as a referral system really anymore at all. It needs to be the Bosnet way. And I keep getting all of these emails from people who say, I can't find the referral, the patient says I've got a referral, please do a Bosnet referral a few months later.
But Luigi tried and you can't.
No, I tried and I can. So I don't know what Luigi's problem was and have to find that out, but it's definitely possible.
For all specialties.
Well, I haven't tried all the specialties.
Yeah.
So that email you sent around, that works?
Yeah, I tried it the other day. Yeah, absolutely works.
So do we all do that?
Yes, we all
You
should
should-
do that.
you
Yeah.
should
The
do it
fax
from now on.
referral
The fax
thing should be
referrals.
thrown in the bin, to be honest, because they're not acknowledging
Pointless.
that as an accountable way of referral.
Are they going to tell me show us how to do it? Or we just read it?
I
So
don't think
John,
they're going
before you
to
go
show us.
on
Yeah.
to the concerning nature, if we're not going to get other units involved at all, have they given us fairly good criteria for when they want to see the patient for fax and all that sort of stuff?
No.
Because we probably need that, otherwise there's going to be a group of patients that aren't going to get appropriate long-term.
So I've got a meeting with Anne-Marie Southcote in a few weeks' time, probably about this specific issue, and then we'll have to try and involve the thoracic surgical team as well. Yeah.
Were you just in context of, sorry John, but that was the context where we had sent someone to a respiratory clinic with a more than 60% pneumothorax, which
So
Anne-Marie
we'd sent someone there
Southcote.
with a total collapsed lung,
Yeah.
with radiological tension reported as radiological
Yeah,
tension.
so that's
However,
always
the patient
issue.
walks into clinic
Yeah.
and has a discussion, and
So in actual fact, she found that on the fax machine. She just happened to be there.
Yeah, but it was actually a sunshine patient that she'd asked her respiratory reg when she saw the fax from us to recall the patient to Footscray, so hence the patient ended up in Footscray with the chest tube admitted under respiratory with cardiothoracic input. So the issue with that whole what to do with the large pneumothorax, as Anne-Marie South had suggested, we sit down with thoracics and respiratory and come up with a pathway that we all agree to. And I think that's probably what we should be looking at. Because there's no point in us managing all that, because if there's no backup plan for these patients, then we can't take responsibility.
No, I'd be controversial and say, honestly, if I saw a 5 centimetre pneumothorax and you walked in and you have some symptoms, you put a Cook's catheter and aspirate it and say, I'm going to deal with it, there you go, done. Because actually I could put a Cook's catheter in 5 minutes, put you in EOU, and then watch it, and have it all done in 4.5 hours and say, see you later.
Would you have them followed up?
I'd send them to a respiratory clinic in 8 weeks' time and say, can you have a chat about whether you have a CT scan or you're smoking or your
So the
recreational
difference
drug
there is that
use.
you've actually done a management.
Yes,
And
I've managed the problem.
Was this patient that caused the problem had not had any management? So being referred, having conservative management, and then the problem being that then they don't know when they're actually going to see the patient. They can't guarantee that that patient will be seen. Clinic.
Just so you know, there is a big study coming out of Monash Medical Centre across Australasia, New Zealand. We've got Monash, Charles Gardner, Gold Coast, New South Wales, New Zealand, on large primary pneumothorax. They have a conservative treatment arm, randomised on arrival, and you need so many sites so that you actually accrue enough patients to make the study relevant. They had a really good sort of how do you get into the conservative side and when do you get out if you've got any sort of symptoms. So I thought this should probably be on our EOU pathway of just really simply, if you've got a big one, breathing oxygen okay, SATs 90%, reassessed in 4 hours in short stay, repeat chest x-ray. If it all looks the same and the patient's fine, then you can go home. But I assume they have a really good follow-up in place for this randomised study so that they have a report back at a month, 3 months and 6 months. You don't have that.
That's the bit we're missing.
Yeah.
So that's why this whole discussion
But
is.
I don't think respiratory, I haven't clarified this, but if we're managing things conservatively, I think the respiratory team want to see them like within a few days.
Respiratory or thoracic?
No, respiratory.
It's also not thoracic.
And just to quickly answer the question of what do I do once I put a catheter in, then this is their interventional arm study. So small bore, Seldinger chest drain, less than 12 French. Check after an hour, repeat chest x-ray. Looks like it's improved. Close the 3-way tap. Another 4 hours later, and get another chest x-ray. And then if they're well, you can just take it out. But again, they'll be followed up somewhere in that system very well. I know that our problem is the follow-up, and that is obvious.
And different people's thresholds for worry, yeah? And the difference between what it looks like on paper and on x-ray versus looking at the patient.
Having done the original study from a 410 on how quickly primary spontaneous pneumothoraces actually are resorbed if you treat them conservatively. This was across both campuses, and Anne-Marie and I published it. It takes a long time. Like, it takes a really long time. So I think if you're actually asking someone to put up with that for a long time, they have to have really good follow-up, or they won't put up with it.
Yeah.
They'll need quite a lot of reassurance at the different
And that goes
phases.
into that conversation, because often people, the conversation about do you want treatment or not is do you want a needle put in you, it's going to be painful and yucky and you're going to have to stay in hospital for a little while, and you know, and everyone says no, right? They don't want any of that. But the corollary is that do you really want to put up with this pain and not really be able to do your activities that you want to do for much longer?
I'd argue that honestly putting in a Cook's catheter is probably the same as just getting a cannula.
But I'm just saying that that's
You know
not
how you
necessarily
phrase
the
it,
way
it's
they
like, do you really
perceive
want
that
me to
to
do a
be.
lumbar puncture for your subarachnoid because it's really going to hurt?
Yeah.
Versus I can do it really simply and just do a lumbar puncture with some local anaesthetic and you'll feel fine. And I'll send you home in 6 hours'
Yeah.
time.
So it's about the way that we display the information as well.
Okay,
With a
done.
system.
Yeah.
Thanks, John.
Thank you.
I think what we're ready to do is just change.